It is now my pleasure to introduce today's program, Congenital CMV, a silent risk to newborns. The problem is much bigger than you think. 1 in 200 babies are born with congenital cytomegalovirus. It is the leading cause of deafness in babies born in the United States. Of the 90% that are born asymptomatic, 43% will pass the hearing test even though they are infected with congenital CMV. This webinar will review the disease state of congenital CMV, including incidence, importance of early detection, diagnosis, and disease management, which can impact patient outcomes. I would now like to introduce today's speaker, Dr. Shannon Ross. Dr. Shannon Ross is an Associate Professor of Pediatrics and Microbiology in the Division of Pediatric Infectious Diseases at the University of Alabama at Birmingham. Dr. Ross earned her medical degree from the University of Alabama School of Medicine. She completed her pediatric residency and pediatric infectious diseases fellowship at the University of Alabama at Birmingham. During her fellowship training, Dr. Ross also earned an MSPH in clinical research at the University of Alabama School of Public Health. Dr. Ross is an active clinician and researcher, with her research focused on the natural history and pathogenesis of congenital cytomegalovirus infection, with special emphasis on translational research exploring virological markers of outcome and CMV-related hearing. At this time, again, it's my pleasure to turn today's program over to our presenter, Dr. Shannon Ross.
Good afternoon, everyone. Let's get started. I'm going to start off today with my disclosure slide. I will be discussing the use of unlabeled drugs for treatment of congenital CMV. So just as an overview, as has already been mentioned, congenital CMV is very common, and it's actually the most common infection affecting newborns annually, about 0.5 to 1 per thousand. And it can result in long-term sequelae, which includes cerebral palsy and blindness. But the most common outcome as a result of congenital CMV is hearing loss, and it's actually the leading non-genetic cause of hearing loss in children. And of all children with congenital CMV, approximately 15% will have hearing loss. This slide shows the disease burden of congenital CMV relative to other common diseases in newborns. And the x-axis shows the annual number of U.S. children with long-term sequelae. And what you'll notice is actually congenital CMV disease causes more disease annually than common things that everyone knows about, like Down syndrome, fetal alcohol syndrome, and spina bifida. And the Institute of Medicine estimated in 2000 that the cost of disease due to congenital CMV is over $1 billion annually. So this is a significant burden in the U.S. With regard to hearing loss, this figure shows the hearing loss causes in children at birth on the left and on the right at 4 years of age. And it's estimated at birth that CMV accounts for about 20% of causes of hearing loss. And then by 4 years of age, CMV accounts for about 25% of hearing loss in children, with the significant other causes due to genetics. So a significant contributor to hearing loss causes in children. So this slide demonstrates some new data on congenital CMV epidemiology, and this was from a large study called the CHIME study. It was funded by the National Institutes of Deafness and Communication Disorder. And in this study, over a 5 to 6 year period, over 100,000 newborn infants were screened for congenital CMV around the U.S. at 7 different sites, and our site at UAB was the main site. And from this study, we found that the prevalence of congenital CMV was 4.5 per thousand live births, and this was within the entire population we screened. An interesting thing to point out is the prevalence difference when you look among races of children. So the highest prevalence of congenital CMV was actually found in the Black population, and approximately 9 per thousand live births are found in African American or Black infants. The prevalence is still significant but smaller in both Hispanic and non-Hispanic whites, with approximately 3 per 1,000 live births. Asians was also a smaller prevalence. And the multiracial population in our study, obviously the error bars are quite large, but approximately 7 per 1,000. So this is a common infection overall, but there are certainly racial differences in the occurrence of this infection in newborns. So moving on to clinical disease and congenital CMV infection. So infants who have clinical symptoms, where you can observe an infant in the newborn period and they have consistent symptoms with congenital CMV, occurs in about 10% of children. And the majority of infants with this infection are born looking completely healthy, completely asymptomatic. So among the 10% born with some symptoms due to the infection, the newborn disease can actually range quite a bit, and it can be very mild. Some infants are born with very nonspecific findings, such as isolated petechiae or just enlarged liver or spleen. And then there's the classic child that we think of with congenital CMV who can have multiple organ involvement, which is shown in the picture on the left of this slide. In past literature studying natural history of congenital CMV, there's not been a standard definition of symptomatic infection, but towards the end of this presentation, I will talk about some newer publications which have tried to better define symptomatic infection. So this is a cohort of children that were followed at our institution years ago, and this is the symptoms that children had, and these are 178 infants with symptomatic congenital CMV. These children were identified either by newborn screening, and that's the column on the left, or these infants were referred for a natural history study from other institutions. And certainly all these infants had this sort of classic symptoms we think of, but depending on how they were identified, the frequency of these symptoms were somewhat different. Infants who were referred tend to have more severe symptoms, but as you can see, the majority in both populations had petechial rash, over half. Approximately 40 to 50% had jaundice. Microcephaly was quite common, somewhere between 30 to 50%, and smaller percentages had seizures and chorioretinitis. When laboratory and neuroimaging was performed on these infants, over half had elevated liver enzymes, thrombocytopenia was common, and in both groups, neuroimaging abnormalities was a significant finding, with calcifications, which are the classic findings we see with congenital CMV infection on neuroimaging, occurring in about half of symptomatic infants. So hearing loss, as we've mentioned, is the most common sequelae due to congenital CMV infection. And this, again, is data from the CHIME study that I previously mentioned, the large screening study. And in this total cohort of over 100,000 babies screened, approximately 400 had congenital CMV infection, and hearing loss occurred in 12% overall. And this is both hearing loss at birth and hearing loss that was delayed in onset. And it's important to point out here that sensory neural hearing loss at birth is defined as the presence of hearing loss at the first full audiologic evaluation at enrollment into follow-up. So this is not the hearing screen. A refer on hearing screen does not always mean hearing loss. So this hearing loss is defined as that when they were first evaluated by a full audiologic exam, they had hearing loss. And in our cohort, we had about 9% of infants who had hearing loss detected within the newborn period. The next few slides are additional data looking at hearing outcomes in congenital CMV, and this is probably one of the largest described populations of hearing outcomes. So this is a cohort of over 800 children who were followed long-term for hearing outcomes. And overall, and among the symptomatic infants, 40% developed some sort of hearing loss, and among the asymptomatic infants, approximately 7 to 10% had hearing loss. What's important to look at is actually the characteristics of this loss. Symptomatic infants in general tend to have more bilateral loss. Asymptomatic infants tend to have more frequently unilateral loss. Delayed onset of loss, meaning it occurs later, past the newborn period, occurs in both asymptomatic and symptomatic infants. But I think a really important point is to look at the median age of delayed onset loss. So in symptomatic infants, it was 33 months, but in asymptomatic infants, 44 months. So children are almost 4 years of age on average when they develop this loss. And if you look at the range of age of hearing loss occurrence, it's quite broad, and some children have been described to have hearing loss almost into their adolescence. The degree of hearing loss does not really differ a good bit between both asymptomatics and symptomatics. And as you can see from this slide, severe and profound loss occurs in somewhere around 60 to 70% of infants with both symptomatic and asymptomatic infection. Another important feature about congenital CMV hearing loss is the fact that it fluctuates. So we can actually see infants who have hearing loss detected, and at their next hearing evaluation, we see improvements in their hearing threshold levels. This occurs much more commonly in infants with asymptomatic infection, and in this particular report, about 48% of asymptomatic children had fluctuating loss, and about a fifth of symptomatic children. And what we often see with children who have fluctuating hearing loss is it will often fluctuate early and then often either stabilize or drop off further, have progression of loss. But this is a characteristic that's somewhat unique to congenital CMV hearing loss. So let's move on to the diagnosis of congenital CMV. So an important thing to remember is this is a congenital infection, and so diagnosis of congenital CMV requires that you detect the virus in the first 2 to 3 weeks of life within the newborn period. If you detect virus after 21 days, this could reflect perinatal transmission, so that would not be congenital. Serology is not useful to diagnose congenital infection in the newborn, and this is due to maternal transfer of IgG, and also the IgM assay is really not sensitive in newborns. So the gold standard way of diagnosing congenital CMV is to detect the virus, and the virus is shed in the saliva and urine in large quantities in infected infants. Blood has much lower levels of virus compared with saliva and urine, and I will show some data to reflect this in a few slides. Traditionally, viral culture methods have been used to diagnose congenital CMV, but the traditional methods actually take 2 to 4 weeks. In the 90s, there were rapid culture methods that were developed that use monoclonal antibodies. These are the Shell-Val assay. And although it is much more rapid, it's quite labor intensive. So over the past decade, there's been a lot of interest in looking at other methodologies to diagnose congenital CMV and using PCR methodologies. And again, the next few slides, I'm going to show data from the CHIME study where we tried to identify the best method to screen newborns for congenital CMV. And when we started this study, we were interested in using dried blood spots because this is obviously something that's obtained on all newborns for newborn screening. And this study was designed, and these diagnostic methods that we were testing were compared with what was considered the gold standard, the saliva rapid culture. And this is data from over 20,000 infants in which both dry blood spot PCR and saliva rapid culture was obtained. And what we found that the sensitivity of dry blood spot was actually quite poor for newborn congenital CMV screening. And we had 64 infants that were actually negative, that were positive on rapid culture. And the sensitivity overall of this assay, based on these 20,000 infant screen, was less than 40%. So really not a good way to catch all infants with congenital CMV. Because saliva rapid culture was readily used, we quickly adapted this and compared the rapid culture to saliva PCR. And we used two methods for this part of the study. We used both what we call a liquid saliva PCR, which used the liquid culture media, and a dry saliva, where you actually collect a dry swab and it's processed in the lab and tested. And I apologize that my red boxes are a little off. The important thing to point out is the sensitivity of both of these assays compared to the gold standard was very high, 97 to 100%. The specificity was excellent. So this is really what we feel the best method to screen newborns for congenital CMV because it's very easy to obtain and the sensitivity is superb. So this is, again, data from the CHIME study, but this really demonstrates why blood is not the best media to use to try to detect the virus in these newborns. And this is viral load, and this is based on the international standards. And as you see on the left, the bars are the median levels, but the median level of virus in saliva in these newborns was over 6 logs of virus, so large amounts of virus, compared with dry blood spots, which was only about 3 logs. And again, it's to point out, even among the positive dry blood spots, only 40% were positive. So there's a lot of virus in the saliva. It's easy to obtain, and this is really why we feel it's the best method to use to screen these babies for congenital CMV. So one question that often comes up about using saliva in the newborn period to test babies for congenital CMV is the issue of breastfeeding. Certainly we know that women who are CMV seropositive can reactivate CMV in their breast milk, and potentially this could interfere with testing and cause false positive results. So for the CHIME study, we did not collect specific breastfeeding information on all of our babies that we screened. However, we used our false positive numbers and published seroprevalence and breastfeeding rates to try to get a sense of what the contribution of breastfeeding would be to saliva false positives. So I'll walk you through this slide. It's a bit complicated, but just the first thing to point out is overall our false positive rate in this study for using saliva was very low at 0.03%. So only 23 of over 74,000 infants screened had a false positive. On the left-hand column, this is the number of infants that were screened based on their individual race and the number of false positives. We obtained CMV seroprevalence data by race from NHANES published data, and we also, I didn't include a column here just because of size limitations, but we also got breastfeeding rates also from published CDC data. This allowed us to calculate the number of infants at risk based on seroprevalence, and I do need to note that we assumed for these calculations 100% shedding of CMV in the colostrum, which really is an over assumption, and we know that not all women will have CMV in their colostrum. But the right-hand column shows the adjusted false positive rate based on breastfeeding alone. And as you see again, the rates are quite low. The lowest being 0.03% up to the highest of 0.14%, still less than 1% false positive rate that could be contributed to breastfeeding. So breastfeeding is really not an issue causing significant false positives using saliva to diagnose congenital CMV. So this webinar is obviously sponsored by Meridian, and they have recently developed and are now offering the Alethea CMV assay. So this is an FDA-cleared test, and it's the first for aiding in the diagnosis of congenital CMV in the first 21 days of life. It is a saliva-based assay. It's a molecular test. It is a LAMP method. And these few pictures show the ease of the workflow, and it requires using a dry saliva swab, put it in transport media. There's minimal processing required. And what's important is you get the results back in less than an hour. So there's minimal hands-on time and minimal sample prep. So this is an important addition to what we already have to help us diagnose these infants. So, as I mentioned, most of these that I've discussed, diagnostic methods are using saliva. Obviously, urine is another common body fluid that is used to diagnose congenital CMV. And this is, again, going back to the large CHIME study, this is data where we looked at, because there's not been previously a lot of data comparing urine saliva PCR with culture methods. So using our infants that we confirmed had congenital CMV and had both urine and saliva PCR and culture done, and these samples, I must mention, were taken within the first month of life to confirm the infection. But we performed both PCR and culture on these samples, and we found that using urine and saliva, both to diagnose congenital CMV, is equally effective, and actually PCR performed a little bit well, and there were three urine samples that were positive on PCR that were negative by culture. And the same, we saw 2 saliva samples positive by PCR and negative by culture. So again, if you have a child that clinically you're trying to diagnose congenital CMV, the PCR methodology of saliva and urine is perfectly acceptable and sensitive to do this. So there has been increasing interest because of the importance of congenital CMV in childhood hearing loss. There's been an increasing interest in the best way to try to identify these infants. As mentioned, 90% of these infants are clinically asymptomatic. So unless we were to test for congenital CMV at birth, we would not know that they have the infection. So there's been a lot of interest on how can we identify these infants. And this is, again, data from our CHIME study, but this is looking, and this is sort of taking lessons learned from newborn hearing screen, but again, is there a way that we can target our screening? So is there a way to identify infants that may be highest risk for having CMV-related hearing loss and test those infants for congenital CMV? So this is using a targeted approach to congenital CMV screening. And this is all of the children that were in the CHIME study. So again, over 100,000 infants that we screened for congenital CMV who also had newborn hearing screening. And what you'll see is we had 443 CMV positive infants, and the refer rate, the hearing refer rate was 7%. This is much higher than the CMV negative infants. The hearing refer rate was approximately 1%, which is typical for what we see in most hospitals. So clearly this may be a way that we can identify some infants at risk for congenital CMV. Now, will this identify all children? If we just screen infants who refer on their hearing test for congenital CMV, will this identify all children with congenital CMV at risk for hearing loss? And this data shows that it won't. It will identify many, but not all. So these tables shows our children with congenital CMV infection and their newborn hearing screen results. So these are just infected children. And what we found that among children who referred on newborn hearing screen, 65% had hearing loss, but 11 did not. And this is not uncommon for children to refer on hearing screen and then once they have a diagnostic audiology exam have normal hearing. But also we found that there were 15 children who passed their newborn hearing screen who had hearing loss. So the newborn hearing screen missed their hearing loss, and this is hearing loss at birth. So if you were to test these children by the targeted method, these 15 children would obviously not be identified. So the newborn hearing screening identified only 57% of CMV-related hearing loss in the newborn period. So we're missing some children by using a targeted approach to CMV screening. Even though this approach is not perfect, it is being used in many states. And this is a slide from the National CMV Foundation, and they update this information regularly. And this is congenital CMV legislation that is currently either in place or being proposed around the United States. And every time I look at this, every time this map is updated, there's more and more colored states. So certainly many states have interest in either education or targeted newborn screening to identify infants. So even though, again, it's not the perfect method, it is a great way to start, and we are going to identify some infants. But what is the difference if we use targeted versus universal screening? So again, only testing babies by a targeted method who refer on newborn hearing screen, or if we test all babies at birth like we do for other newborn diseases. So I'll walk you through this slide. So, we estimate that of the 4 million births per year in the United States, 5 per thousand will have congenital CMV. This results in about 20,000 infants with congenital CMV per year. To the left-hand side, 10% of these will have symptomatic infections, so about 2,000. About 28% of these would refer, from what we know from our recent data, they would refer on their newborn hearing screen. So they would go on to have follow-up testing and be identified either as having or not having hearing loss. The other 72% symptomatic we would think would be identified clinically. So they would be picked up by a clinical exam and be tested for congenital CMV and monitored. The infants on the right are the ones we're really concerned about. So 90% of infants are born asymptomatic. So we have 18,000 infants a year born completely healthy appearing in the nursery. Now, only 5% of these infants will have a referral on newborn hearing screen. And so these infants will obviously, potentially, if you use targeted screening, be picked up. But there's an additional 95% of these infants who will pass their newborn hearing screen. So if we were only doing targeted screening, we would not identify these infants. And the only way to identify them is by universal screening. And among these 17,000 infants, over 50% are at risk for having hearing loss. So we're going to miss, approximately 8,000 to 9,000 infants at risk for hearing loss if we're only using targeted screening. So I'm going to move on now to treatment and management of infants with congenital CMV. Unfortunately, we don't have a great availability of medications to treat infants for congenital CMV, and ganciclovir or its oral prodrugs valganciclovir are really currently our only options. Now, this medication is certainly has some toxicities. Known toxicities we see in treating patients are bone marrow suppression and neutropenia. Based on early animal models and studies in animals, there are potential toxicity to valganciclovir of carcinogenic and gonatotoxic, and this was again shown in early animal models. So the standard of care currently for treatment of infants with congenital CMV was really based on this study, and this was published by David Kimberlin, Rich Whitley, the Collaborative Antiviral Study Group in 2015. And this was a randomized treatment study where they treated infants only with symptomatic congenital CMV. And they compared two treatment arms, 6 weeks versus 6 months, and 6 weeks at the time was the standard of care. And their primary outcome for this study was hearing loss at 6 months, and they followed these infants out for 2 years to look at hearing outcomes. And what they found is at 6 months, there was really no difference between the longer and the shorter treatment arms. So the 6 months and the 6 week, there was no significant difference in efficacy. However, at 12 months and 24 months, children who were treated with a longer treatment arm of 6 months had better hearing outcomes with either improved or stabilization of their hearing thresholds. So this really established the standard for treatment of infants, and this is only for infants with symptomatic congenital CMV. So, as I mentioned early on, there's not been across the literature and studies good definitions of what symptomatic congenital CMV infection is. There's been a sort of a whole host of definitions depending on the institution or the study. So in 2017, there was a consensus guideline that was published. Now, this guideline was put together by a group of experts in both maternal and congenital CMV infection, and the guideline covers both maternal and congenital CMV. But they actually classified congenital CMV infection, and this allows for better ability to know who to treat. They define symptomatic congenital CMV as moderate to severe symptomatic disease. So these are infants who are readily identified by clinical exam. So they typically have one or more symptoms that is easy to notice in the newborn nursery. And these are symptoms such as thrombocytopenia, they have microcephaly, large liver, large spleen. Now they classified a mildly symptomatic category, and these are infants who have maybe 1 or 2 mild manifestations of congenital CMV. So an infant may just have diffuse petechiae, they may have petechiae and enlarged liver and spleen, but for the most part are not ill from the disease. Another classification was asymptomatic congenital CMV with isolated hearing loss. So these are infants that appear clinically normal, but they do have, based on audiologic exam, they do have hearing loss within the newborn period. And again, this is not a failed hearing screen. And the last classification were asymptomatic congenital CMV with normal hearing. So these are perfectly healthy kids. They have no outward manifestations of the disease and have normal hearing within the newborn period. And so this classification system was used so they could make recommendations on who exactly, where the data shows to treat infants. And this consensus recommendation for treatment of congenital CMV recommends that symptomatic, the first category, symptomatic congenital CMV disease, and that's moderate to severe disease, is really the only group that they recommend routinely treating with valganciclovir. And that's because that's really the only population that was studied in the randomized trial I previously cited. Most of the infants that were included in that 6-month treatment trial were fairly significantly affected by CMV. There were really very few, if any, mildly affected children. And the recommendation is to treat for 6 months with oral valganciclovir, and the treatment should be initiated within the first month of life because this is how the study was set up. And obviously, we have to monitor for side effects from the medication. An important thing to note is viral load monitoring is not indicated while infants are on treatment because there's not been any data to show that it correlates with a treatment effect. And actually, the CASG, who published the treatment study, recently published this, and that viral load levels really, in response to treatment with viral load, does not really correlate with treatment effect. And again, the treatment duration for valganciclovir in this population is 6 months. So the other groups, the children with milder symptomatic disease, the children with just isolated hearing loss, antiviral therapy is not routinely recommended because it really was not studied in these populations. I will note that there are currently several studies underway to study infants with both isolated hearing loss and asymptomatic infants, so we hope we will have data in the coming years on efficacy in these groups. And also as a reminder, antiviral therapy is not routinely recommended in infants less than 32 weeks because it was not studied in the premature infants. So for the last few slides, I'm going to discuss evaluation and follow-up of infants with congenital CMV. And this is something that's not been published by a consensus group. It was not in the consensus document that I just discussed. And this is how we personally at UAB, at my institution, evaluate infants. This is sort of our standard of care. So for symptomatic infants, at birth, they obviously need a good physical exam to document their symptoms. We routinely get labs on these infants to check a CBC and their liver function tests. And we also routinely do neuroimaging either by a sonography or now with more rapid MRI methodologies and brain MRI. We routinely recommend an eye exam to look for chorioretinitis. And then obviously they need hearing testing, not just the hearing screen. Even if an infant passes their newborn hearing screen, they still need a diagnostic audiologic exam in the first month of life. And then for follow-up, we typically recommend hearing testing at least every 6 months until age 3. And this is for infants who have normal hearing at each testing. If hearing loss is detected, usually the audiologist might recommend more frequent testing. And typically we recommend testing annually age 3 till age 5 or 6. And there's some question about really how long we need to do thorough audiologic exams. As I mentioned earlier, there has been some documented hearing loss due to congenital CMV in late school age and early adolescence. And then development needs to be followed closely in infants with symptomatic congenital CMV. We know they're at higher risk for developmental delays, particularly if they have any neurologic involvement. And so careful developmental assessments need to be done. For infants with asymptomatic congenital CMV at birth, again, we do a thorough physical exam to assure that they don't have any symptoms. We routinely do not check laboratory values if the infant otherwise looks completely normal. We will recommend an ophthalmologic exam to evaluate for retinitis. And again, they need hearing testing within the first exam being within the first 4 to 6 weeks of life. And the follow-up is the same as for symptomatic. We recommend hearing testing every 6 months until age 3, and then annually until age 4 to 5. And again, careful developmental screening assessments are important. So I'm just going to do some summary now to wrap up. Again, congenital CMV is a common infection. Approximately 1 in 200 babies in the U.S. are born with this infection. And they can present with a wide range of symptoms. They can be very mildly symptomatic, but the majority of infants are completely asymptomatic, and unless we test them, we would not know that they were infected with CMV. Hearing loss is the most common sequelae of congenital CMV, and nearly half of it is delayed in onset and could be missed in the newborn period. Saliva is really the preferred method for newborn screening due to the ease of collection, and also we know that testing by PCR method is highly sensitive, but it's really the ease of collection that makes it the preferred method. Treatment with antivirals is reserved only for infants with more symptomatic, moderate to severe symptomatic infection. And it's important to remember that even though we don't have antivirals for all infants with congenital CMV available, that hearing aid and speech therapy, those are important interventions for infants with asymptomatic infection. That's why we really want to identify these infants early, that they have hearing loss early, because these are certainly treatment options that we know can improve outcome in infants with hearing loss. So I will finish up there, and I thank you for everyone's attention, and we'll wait for questions.
Thank you, Dr. Ross, for a very informative presentation. It is now time for our question and answer session. If you would like a question answered, please feel free to click the Q&A button on the lower left-hand corner of your screen. Please type your question in the open area and click Ask to submit. So we have several questions for you, Dr. Ross. Our first question that has come through: did the CHIME study distinguish congenital CMV infection due to primary and secondary infection, primary versus reactivation?
No, we did not do any maternal testing on these in this population to know which infants were born due to non-primary infection or primary infection. So we don't have that data.
Okay. Thank you, Dr. Ross. Next question. Jaundice is relatively common in newborns. Would jaundice be useful as a marker of risk for congenital CMV or an indicator that an infant should be tested for CMV?
That's a good question. And the jaundice due to congenital CMV is direct. It's a direct hyperbilirubinemia, and we say usually greater than 4 is the level that we typically call sort of a symptom. So if you have an infant that has a direct hyperbilirubinemia in the newborn period, I think that definitely would be a good reason to check that infant for congenital CMV.
Thank you, Dr. Ross. Our next question: Ontario, Canada's public health region, has recently initiated an enhanced newborn hearing screening program, which includes universal screening for congenital CMV. According to data presented at the CMV Public Health and Policy Conference this past September in Burlington, this team from Ontario was able to achieve excellent sensitivity rates for identifying congenital CMV and routine newborn blood spots. They described their method as an in-house assay. Do you see needing to add saliva screening versus being able to use existing blood spot protocols as an important barrier to universal screening for congenital CMV? And secondly, do you feel that advocacy for saliva testing is the best long-term strategy?
So there's certainly been in the literature various groups that have used dry blood spots for congenital CMV screening, and one of the challenges is that there's different extraction methodologies. Dry blood spot cards can have different amount of blood on them, so that's probably why we're seeing different sensitivity due to different dry blood spot methods. I think there's been data across many different studies showing that not all children with congenital CMV, and this is even in children with symptomatic congenital CMV, are viremic. So there's still a chance that we will miss virus in the blood in these infants, and that's why I really feel like saliva alone is the best and easiest method to use for congenital CMV screening. Advocacy, certainly, I think a lot of education on the use of saliva would be important, yes. Sort of advocating and educating about why this is the best method to use.
Thank you, Dr. Ross. Our next question, if valganciclovir treatment is not correlated with CMV load, how is the hearing improved in moderate to severely affected children?
We really don't know. I mean, that's a great question. We don't fully understand the pathogenesis of congenital CMV. I think that we think that it likely affects viral replication in the inner ear. We know that virus gets in the inner ear. There's some data to suggest that there's an immune response to the virus that can contribute to the pathology of CMV hearing loss. I think the important thing to realize is viral load in the blood is not an indicator of viral effects in the inner ear. We're trying to use peripheral blood as a marker for central nervous system viral involvement. So that's really not why. And the data's really shown that it doesn't correlate well. Children with normal hearing can have high amounts of virus. The ability to clear the blood on treatment has not shown necessarily to correlate. So I think, again, the take-home message is peripheral viral load is not a good marker for central nervous system inner ear viral effect.
Thank you, Dr. Ross. Next question, any recommendations to reduce viral transmission?
So behavioral, I assume what that question is asking is more about acquisition of CMV in the mom. And there have been a few studies looking at behavioral interventions to reduce the chance that moms acquire this virus and thus transmit it to babies. And there's been some evidence in primary infection that certainly this can be beneficial in reducing maternal acquisition of CMV. I don't know that there's official recommendations yet because the data is not quite there, but I think there's some evidence that it can be useful, behavioral sort of, maternal education about behavioral changes that you can do to reduce the chance that moms acquire this infection while they're pregnant.
Thank you, Dr. Ross. We've had time for a couple more questions. Next question, recommended timing of saliva collection after birth on breastfeeding infants to avoid false positive testing, incidence of false positive saliva PCR testing with breastfeeding infants.
Right. So, the data I showed on our false positive rates from the CHIME study was infants that were screened for congenital CMV in the newborn period, so that was within the first 2 days of life. So as far as age of the infant, you'd like to do it within, you want to do it in that newborn period, within the first few weeks of life to know that's congenital infection. The timing of actual collection, although there's not a lot of data to support this, we typically would try to collect our saliva at least an hour after nursing to hope to reduce those chances. Again, there's not a lot of data to support this, but that is how we performed our testing in the newborn nursery in the CHIME study. I think that answered all the questions.
Thank you, Dr. Ross. Our last question for today, if a child is much older than 5 years with difficulty hearing, can CMV detect since not tested early in its life?
So I think what that question is asking is if a child has hearing loss in an older age, so 4 or 5 years of age, if you test for CMV, will that tell you if CMV is causing the hearing loss? And the answer is no. And that's why identifying these infants early is important. Most healthy children, or many healthy children, acquire CMV after birth, and it causes no problems. So a healthy child can acquire CMV after birth, and so you can detect it in that child. But testing a child for the first time for CMV at 4 or 5 years of age will not tell us if that child acquired the virus after birth or congenitally. So again, that goes back to the importance we need to identify these infants within the first few weeks of life as having definitively congenital infection to know that that's what's causing the hearing loss.
Thank you, Dr. Ross, again, for a very informative presentation and Q&A session. Thank you to all of our participants for joining us today. We do hope you found this webcast presentation informative. We did have a couple of questions come in at the very end, but we will be sure to follow up with you to get all of your questions answered. So again, thank you for joining us, and this concludes our webcast today. You may now disconnect and have a